Yeah, so I'm going to start, as Michelle mentioned, by really trying to set out the advantages and disadvantages and the various relative differences between the MRI proctography and barium proctography, particularly as it's pertaining to the diagnosis and management of obstructed defecation. But as we know, it's, we're using this primarily to do one of two things, either to diagnose or exclude a functional cause or structural abnormality, primarily rectal or intussusception prolapse. Although I know in the literature now, over the last approximately 10 years, most of the literature, certainly within the radiology publications, focuses on the use of MR proctography, but actually there's still quite an important role, and I'm going to try and set out what are the relative advantages and disadvantages between these two techniques. So I've shown a picture just to give those people who haven't actually seen the setup some of the realities, and also just run through the technique. So there's two broad options when you're doing a barium proctogram. We tend to use a fixed volume of barium paste, or the other option that I know certain other centres use is to use a volume until you get a sense of urgency, and so that typically will be a larger volume, but it's not always the case. The other thing, that just to explain that there's a difference between two ways that certainly in the UK centres will either do what we describe as fluoroscopy. So in other words, you don't take actual exposures, but you have continuous fluoroscopy. But then sometimes there's advantage and disadvantage of both the technique of just doing so-called a fluoroscopy and capturing a continuous video loop effectively, and individual exposure. So in broad terms, the advantages of fluoroscopy, you can get a much higher frame rate. So you can imagine it akin to getting a video clip as opposed to taking a series of rapid photographs. So the advantages with fluoroscopy, then you can get a higher frame rate. So our machine, for example, will give us up to 7 frames per second, whereas typically exposures, partly because of dose, but partly also because of the other technical reasons, you would typically get a frame per second. Now, obviously, the key difference there is that the radiation dose is obviously something that we are going to be very concerned about, particularly in young patients, and there is a much lower dose with the use of fluoroscopy as opposed to taking x-rays, but the flip side of that, though, is that you're not going to get the same detail. So again, using the analogy of a video compared to photographs, you can't get that high resolution with fluoroscopy. So there is sometimes a bit of a balance to get between those two. Now, one of the issues that is obviously from the patient's perspective can be quite significant is the issue of privacy. I mean, the whole technique, whether we're talking about a barium proctogram or an MR proctogram, different people will have different perspective on how comfortable or how it feels in terms of the privacy. But there are a number of ways that we can, try and optimize that environment for the patient. One of the other big discussions about the relative pros and cons of a barium proctogram to an MR proctogram is that obviously with the barium you can do it in an upright position, whereas by and large MR, most people I'd say would do it in a supine situation. One of the interesting things actually that I just thought I'd touch on, because it's just a matter of the practicalities of how our room setup has been created when we recently moved to a new site. We've now got the possibility, and actually have started looking at what effect it has, that the patient is actually able to look at the screen at the same time as they're emptying, and this may have a potential role in education and almost a form of biofeedback. So we're currently discussing that with the biofeedback team, how that may be quite useful actually to see, for the patient to see that in real time. So just talking about MR proctography, some of the similar realities or practicalities. So although in theory people can do an upright scan, but in reality, certainly in this country, there's very few centres that do it. So effectively, pretty much everyone has it as a supine standard in a standard MRI scanner. Increasingly, when you look at the international guidelines, one of the things that has been highlighted is that explaining to the patient what is going to happen is really crucial, to the extent that a number of the guidelines actually suggest that you should have a formal process to actually run through the examination, so it is absolutely clear what is going to happen, just because actually there is a real problem with patients. Actually in the scanner, there's a whole lot of factors that may influence whether or not they're able to empty. One of the other questions that can be raised, because by and large, almost everyone, all the centres would use gel, and typically ultrasound gel, there is a question about whether or not that is an appropriate recreation of the physiological sort of colonic contents. You could also raise the same question about paste. Is that close enough to stool? But most people would probably feel that there is probably a closer equivalence of the paste, the barium paste that most people use with barium proctography as opposed to the gel. One of the other things that people who request these tests don't tend to think of, the practicalities, but the broad two choices that most centres would choose between is either patients in a scanner evacuating onto a pad or into their pants. And you know, when you think about the practicalities of those, neither of those seems like a particularly pleasant option. So it's worth bearing in mind some of these practicalities. The other thing that is been highlighted in the guidelines is that because there's a fair proportion of patients who may not actually empty effectively in the scanner, that to try and actually check if there is some pathology, that there should be a repeat scan after they've actually evacuated. But I don't think that all centres do actually do that, because again, it extends the whole examination, so it makes it a little bit more involved. So I'm just going to show some examples of MR proctograms in those patients who had both an MR and a barium, just to show relative advantages and disadvantages. So this is a patient who was referred with a question mark of anismus. So hopefully this will run. So I'm just not going to obviously show the whole examination, but the emptying segment. And what you can see is the typical picture that we often see. So there's quite a lot of effort. The rectum and the pelvic floor are descending quite low, but it's bobbing up and down, and in the end, they weren't able to evacuate. So the impression given on that examination is that they do have a problem with anismus potentially, but for a few reasons. This patient also had a barium proctogram, and this shows the sort of situation that creates this uncertainty about the validity, in a way, of the MR proctogram. So this is the same patient, and there's a bit of delay with the way the video is playing, but what you can see is actually that they have been able to effectively empty. And I would say that this is one of the key difficulties when you are doing an MR proctogram, of being confident whether or not they do actually have anismus, if that is the primary question. One of the things I haven't touched on, but actually it's a fundamental benefit, and in some ways one of the key utilities of MR proctography, is that you can provide a multi-compartment assessment. So in this patient, we can see not only obviously the rectum, but what's happening to the bladder. It's more the rectum that's descending, really going quite low. And although there isn't significant descent of the bladder, what you can see, if you look closely, that there's urethral hypermobility, and actually there's leak of urine that's just visible below the bladder. So in the way that you'd expect, this is quite helpful to provide an assessment of the anterior and middle compartment, as well as just seeing what's happening to the rectum. But again, this is the same patient who had a barium proctogram as well. And one of the things that wasn't highlighted in that, so they managed to empty, but actually there was an enteroceal that was visible, but I don't think we could appreciate to the same extent how significant that was. And part of the reason that I find a lot of clinicians don't fully appreciate is that the way typically these MR are done, we're only getting a very small central section, typically up to about 10 millimeters. So anything that happens either side of that, and you're not going to be able to fully assess that. So I'm just going to run through the key advantages of the MR proctogram. So obviously one of the major benefits is this is completely radiation free. You've got that assessment of all of the compartments, so a more thorough pelvic floor assessment. This question of privacy, I'll show you shortly a study that shows that there's a sort of a different perception from different patient groups. So some people do actually prefer the relative privacy of the MR suite, but that depends on individuals. And there is the potential to have more soft tissue detail, so not just in the different compartments, but sometimes you can actually get more soft tissue details. The major disadvantage I think most people recognize is that the fact that it's done supine, that you're using gel. I've mentioned about the fact that you've only got this very small central section, and as things currently stand, you can only get a frame per second. So if someone is if things are happening quite rapidly, it can be difficult to capture that. And then because of those factors, then you may have difficulty capturing all of the detail on an MR that you may be able to get on a barium. There was this study published that tried to look in a little bit more detail at the patient experience or perception. And so you can see in different areas that the MR is preferred. There's different elements, as I said, and some people would actually prefer the relative privacy of the MR. But one of the clear differences was in the ease with which patients were felt they were able to evacuate, and that's not surprising, given the fact that you are in a supine position. But I think just a reminder, I often sometimes have the feeling that those people who haven't been in a scanner don't fully appreciate how significant that sense of claustrophobia is. And I think that combined with the fact that you're trying to, as I've hopefully described, set out what the practicalities are, it can be really quite a difficult examination to undergo for patients, and I don't think we should underestimate the impact of that on their overall experience, and then how effective that assessment is. So I'm just going to briefly talk about barium proctograms and the experience now. That last study did suggest that more patients preferred the MR, but I think there is still this question, and I think we need to look at individual patients' preferences. So in summary, I think there's, as I've hopefully set out, there's pros and cons of both of these techniques, and ultimately you're going to be looking at what your local availability and expertise, and really focus on what are the questions that you want to answer. And I think if you've got the option of both, I think if the functional question about, and if there's a high probability of anismus, I think generally most people would accept that barium is probably the preferable choice. But then there are going to be times when actually each of these techniques has their benefit, and particularly if there is a question about multi-compartment or certainly anterior middle compartment prolapse or problems, then I think it would be preferable then really to do the MR to get that overall view. So with that, I'm going to hand over to Greg.
Thanks, Arun. Just a few slides just to put some of these pathologies into context in terms of management. So rectal intussusception, so this is now internal rectal prolapse, not the external variety we spoke about earlier. So this is where the rectum is sort of telescoping in on itself. It should be a straight tube and it starts to drop down through itself there. Now it's been graded into 1 to 5, so grades 1 to 2 are rectal intussusceptions. The rectum pushes in on itself. Grades 3 to 4 are where the rectum starts to intrude into the anal canal, and grade 5, it's in the outside world. Okay. Now, you'll come across this patient will present with obstructed defecation. You'll arrange a proctogram, and that may tell you there's a degree of rectal intussusception. Now, what's happened here? The rectal wall is now giving way and prolapsing on itself. So that force that the force you're exerting to try and enter the rectum is now being expelled into distorting the rectal wall. In some cases, this may progress further down the rectum to produce a physical obstruction to passage of stool, and your proctogram may demonstrate that. Now, these are surgically correctable things. Now, the counter-argument to this is the fact this is actually really common. So a very famous paper by Chauvin from the late 80s took I think 50 or 60 asymptomatic adults off the street and did proctography on them. Around 50% had a degree of rectal intussusception. So this in itself is a common entity. And I bet if you push really hard, you'll probably be able to generate at least a 1 or 2. There's often an underlying functional evacuatory problem with the rectum, so though correcting the anatomy it may not lead to resolution of symptoms. And if you go back into the published literature so in support of rectopexy, which is essentially the operation to correct this, what you're seeing is an improvement in symptom scores rather than complete resolution in most cases. There's often associated rectocele, in fact very commonly so. Our practice is to put these patients through the biofeedback clinic first. If they're still symptomatic at the end, they're brought back to the pelvic floor MDT. They're more likely to come to surgery if the intussusception acts to almost occlude an associated rectocele, so the rectocele cannot empty the contrast that's trapped inside it, or the rectum is dropping down into the anal canal. That's more likely to come to a rectopexy. The rectum will need supporting both posteriorly and anteriorly to really get on top of this and also correct the rectocele, and this will involve the use of mesh. So think carefully how you're going to do this and do use your MDT. Consent the patient very carefully, and they'll often need ongoing biofeedback support afterwards because there's usually an underlying problem with the rectum, which is why it's not emptying properly in the first place. Rectoceles. Now this is protrusion, in our world, protrusion of the anterior rectal wall into the vagina. This is hugely common. In fact, it's probably a normal variant in the older female. It's related to childbirth, age, previous hysterectomy. And of course, there's colorectal and gynecological rectocele. So a gynecologist may come across a rectocele when the patient complains of vaginal prolapse. We'll come across it in a patient with obstructed defecation. Try and unpick what the symptoms are. If it's solely a problem with the rectocele trapping the stool, the patient may have worked out that by pushing back on the back wall of the vagina, they can empty their bowels. They'll complain of a bulge in the vagina and a sensation of stool getting stuck right at the bottom end. A paper from Knowles looked to try and grade these into which are most likely to become symptomatic and come to surgical treatment, and those at 4 centimetres or more are probably the most likely to present symptoms from themselves. Again, back to biofeedback. Try evacuatory adjuncts, such as transanal irrigation above or the FEMIS device to insert in the vagina and push back on the vaginal wall. And then surgery if these fail to improve things. For an isolated rectocele repair, your options are transvaginal or a posterior colporrhaphy. In our practice, we'd engage the services of a urogynecologist. There's a transperineal approach, which I've not really had any experience of, or the transanal, essentially an extended anterior de Lorme's operation. If there's an associated rectal intussusception you want to correct at the same time, then we go back to the rectopexy with the use of ventral mesh, okay? But again, I think this is best suited if there's an associated intussusception or you've got a recurrent rectocele that can't be managed with local repair. Dysynergic defecation we saw in Arun's talk, and this is described as anismus by Leonard Jones of St Mark's in 1985, and this is hugely common. It's also seen in asymptomatic patients as well to confuse the matter. Now, how this occurs is really poorly understood. It's probably an acquired behavioural problem. There's a higher incidence of trauma and psychological problems in symptomatic patients with this issue. You can define it as an inability to coordinate the abdominal and pelvic floor muscles to evacuate stool. So your rectum is pushing against a closed door is probably the way to think about it. Rao attempt to break this down to 4 different phenotypes, but essentially you've got variations on the same theme. So grade 1 is adequate pushing force in the rectum, but the anal canal pressure is paradoxically increased. Grade 2, the rectum's not really expelling properly, but you've still got an increase in the anal canal pressure. And 3 and 4 are where the anal canal is just not relaxing, and you've got either adequate or inadequate rectal drive. Now, I think you should diagnose this on history. So patients will complain of something stool getting stuck. They may use their finger to help empty their bowels. You can examine them in clinic, but there'll probably be a degree of stage fright, so they may not relax appropriately when you ask them to strain and try and push your finger out. Balloon expulsion, usually one of the pelvic floor nurses, is quite helpful, and proctography as well. And I think upright barium proctography is more useful than MRI for diagnosing this. Biofeedback in your pelvic floor physiotherapist is your best bet to try and get the patient out of trouble here. There's been reports of division of pubic rectalis, which I think is swapping one set of problems for another. So Botox is now being increasingly used. Now, there's no consensus on how much Botox is used nor where it's put. In our practice, we'll place this into the pubic rectalis with a patient that's asleep, but still with pretty good contraction of the pelvic floor. And I'll put 50 units into each side and a little bit into the internal anal sphincter. And then they go back to biofeedback afterwards. Botox works temporarily, so in our minds, this presents a window for your pelvic floor therapist to get to work on the patient and get these muscles relaxing appropriately. And in very extreme cases, a stoma may be sought. It can be really difficult to treat if they fail biofeedback pelvic floor physio, and again we mentioned about Botox not being a treatment on its own. Now it's worth looking for this and correcting this first before you go after any intussusception or rectocele, because remember, if the door's shut, the rectum will be pushing hard down onto that closed door, and you'll get distortion of the rectum for your intussusception, your enterocele and your rectocele. So you need to get the door opening first and then see what the situation is then. So in summary, these are all very common disorders, and it's picking the ones that require surgery and the ones that don't, and conservative treatment should be considered in all cases first. Thank you.